before you see it, and that can help align the findings to how you appreciate the scan examination. So I will just take the next few slides to remind us about a few things about the female pelvic anatomy. We can see displayed here the bony pelvis. Let's remember that it's made up of two paired bones, each joined in front by the pubic symphysis and behind by the sacrum. Of particular note is that the ilium is the part that determines the width of the hip. So when we talk about how wide the hips is, we're talking essentially about the ilium. And then the ischium is the bone on which we rest our weight when we are seated. But this is only important to the next image I'm going to show to you, because here you find the soft tissue of the female reproductive anatomy imposed on the bony pelvis. You can appreciate the mons pubis, the labia, and then the space between them called the vulva. It's important to understand all this because they give us that sense of how we appreciate when we conduct scans, moving from anatomy to ultrasound findings. Because that's essentially what ultrasound does, is to show us the anatomy of wherever we're examining. Now, if you look at these slides through the body, it helps to get an orientation of how the different pelvic organs are related to each other. You find the bladder in front, which is below and in front of the uterus. The uterus is above and behind the bladder, and then the rectum is behind that. This again, which is a coronal view, it's an attempt to display how the different components of the female pelvic anatomy are related. The same thing goes with this. You're looking at the uterus, the cervix, and the vagina in the middle. And on the Adnexal structures, you should appreciate the ovary and the tubes. It is particularly important to note that the ovary is usually located below, that's posterior to the tube. And then the round ligament is often in front to these two structures. So it helps you sometimes in getting orientation, even at cesarean section, and not just for the purpose of scanning alone. There is a condensation of the broad ligaments you can appreciate on the sides, around the tube, as well as the ovary, which form the mesovarian as well as the mesosapis. Despite this attachment that the ovary has to the uterus, to the pelvic sidewall through the fundibulopelvic ligament, and even the broad ligament, is quite a very mobile organ. And sometimes it can be very challenging determining the location of the ovary during a scan examination. Something that helps, perhaps, is what I will talk to you about in this image of the pelvic vessels. Because the ovary might have a very variable location, it's important to always look for it around where it's often located in the shallow fossa, just in the angle where the external iliac vessels separate from the internal iliac vessels. Okay, you've often heard of that shallow fossa called the ovarian fossa. That's often where you find it. So if it's challenging getting the ovary during scanning, just locate where you can find the internal iliac vessels, and not too far from there will be where the ovary is likely to be, except it's bound down or some other anomalies. It's making the ovary not accessible. Now, in terms of the orientation of the uterus, we often talk about anteverted uterus, retroverted uterus. We'll show images of this in a few minutes to give us the right orientation. When you measure the uterus, you should take the total length of the uterus, and that means the fundus to the cervix. That's the length of the uterus. And then the anterior-posterior diameter in a sagittal view. Then the last measurement is the transverse diameter, which is taken in the transverse view or the coronal view. And then the endometrium is usually measured, especially in the mid-cycle period when you have the finely defined leaf-like appearance from the anterior to the posterior wall. So the complete distance is what you measure as endometrial thickness, taking the midline echo along. So it's not just one half of it. Some people take one half and say that's endometrial thickness. It should be both across the midline. And then the ovary is also measured in 3 dimensions, the longitudinal axis of the ovary. Then across that will be the anterior posterior. And then you change the orientation of the probe to take the transverse measurement. So this is also displaying the pelvic anatomy. What you see here essentially is an anteverted uterus displayed in segments. At the beginning, you see in this image, it's just showing the vagina. And then by the time you get the probe deeper in, you begin to see the cervix as well as the uterus. So in this top image, you appreciate the uterus. This is the full length of the uterus. It's not all the time you get it so clean like this, but you may be lucky sometimes. Then you see the midline and the bladder anterior to the uterus. Therefore, what you find on this other side will be the rectum. The same image is displayed here, but this time the endometrial thickness is quite defined. Usually what you find in the mid-cycle period where you have a trilaminar pattern. And so you can do a measurement from the top here, which is anterior, to the bottom here, which is posterior. And that is the thickness you will be interested in. So now, what do we have to know about making a choice between a transvaginal probe or a transabdominal probe? It is often said that the transvaginal probe gives more details of the pelvic anatomy. That's because the frequency is quite high, and then the probe is right on the scene, in quotes. You place it close to the organ of interest, and so you're able to see it clearly. Whereas the abdominal probe will give a more general view of the pelvis, but not in details. And so the penetration is better with a transabdominal probe. Whereas the high frequency we mentioned for the transvaginal probe gives excellent resolution. What the low frequency of the transabdominal probe does is to help better penetration, so you're able to see deeper into the pelvis. So these are examples, just line images of what the probes look like. The first of them, which is to the left, is the curvilinear probe, which is traditionally adapted to doing obstetric scanning, maybe abdominal scan for pelvic examination as well. The linear probe is often used for small parts like musculoskeletal examination and vascular examination. It's not a very popular probe with the obstetrician and gynecologist. And so, of course, the endovaginal probe, which has become the second stethoscope of the obstetrician and gynecology. So you're going to find more of the curvilinear probe or convex probe and the endocavity probe, the transvaginal probe in your practice. What do you do in terms of orientation to the image as well as the probe? You often need a guide from what is called the marker or orientation indicator on the probe. And we'll see this in the next slide. It will help you orientate yourself to the sagittal view as well as the transverse or coronal view, and it helps you in determining how you should move. So if you display sagittal view of any organ, in moving to examine it further, your movement should be from side to side. Whereas if you are showing a transverse coronal view, you should ideally move up and down in terms of how you move your probe to be able to get more of the image. Now, these are the planes that you would often come across in your scanning. Talk about sagittal plane. That plane divides the body into two. One part is on the right, the other part is on the left. So you can imagine what that means. You're cutting across the body, and so whatever is in the midline is what you see in two. So if it's passing through the abdomen, for example, it's going to have one part of the liver on the one side, on the right, and a small amount of it on the left. Something like that. So if you move a little more to the right, then you start to see more of the liver. So that's how that works. And then if you go to the corona frontal view, there's a split front and back. And then for the transverse view, the split is up and down. So the more you move up, the more you see organs that are superior, and then the more you go down, the more you see organs that are inferior. So when the probes are put appropriately, this is what you expect in terms of the sector that is developed to see the image. So for a transabdominal probe, the image is shown with a fan out of the sector, and so it is able to show it in that orientation. That's what will be displayed on the screen. Whereas for the transvaginal probe, it starts the same way, but just a reverse. The image also spreads out, and you see more the further away from the probe that you see as at the point where the probe is applied. So this is what I meant when I said the marker. So you can see the red points on the probe. It gives the orientation of where you should be looking at on the screen. So for this particular image, which is showing the uterus, the bladder right in front of it, the probe is supposed to be oriented in such a way that the marker points cranial, or if you change in the transverse direction for scanning, it points to the right of the patient. It is important that you always maintain this orientation. I remember to do so all the time, because a reverse of it will sometimes change things for you, and then you start making wrong impressions. So the marker should always be identified before you place your probe. And one way to ensure that this is often not missed is to just depress on the, before you place the probe, you can touch the probe to determine exactly which position you are in. And so you will see it show on the screen that you are right in the right orientation, and then you can go on with your scanning. Otherwise, there's a challenge with orientation if that is not followed. For the transvaginal, the same thing applies. You often will see the marker on this top, which tells you where you face cranially or where you face the right of the patient when you scan. And that's what you need to be able to interpret your image appropriately. Otherwise, you could call an anteverted uterus a retroverted uterus if you place probe wrongly. So in this upper image here, this is the fundus, and that's to the cranial part. And so what you see caudally will be the cervix. This is anterior because that's where the probe, you can see the probe marker there. And so opposite will be posterior. It's always important. So by the time you change the scanning plane and you get a coronal view, this will be right because again, the marker suggests that you should always place it to the right, and then the other side will be the left. So when you make your movements, the movement for this plane that is sagittal should be, like we said before, side to side, whereas the movement for the plane that is coronal should be up and down to be able to fan through and see the details. So this is just about the same thing, but this time we're giving the difference between anteverted uterus and the retroverted uterus. So here you see the uterus bending over and behind the bladder, and that's what the image will show here. So the bladder is going to be found somewhere here, which means it will be anterior to the uterus. Whereas in this other image, the fundus is to the left, sorry, the right of this image. Or, yeah, fundus to the right of this image, but you can see that it is away from the marker. That's what tells you that the uterus is retroverted. It's away from the marker, and so the fundus. Whereas in this previous one, you can find that the marker is where we're hoping that the person plays the probe properly. The marker depicts where the fundus should be. So it's important that you always follow the rules. So one or more marks that are on the probe, just a summary of what I've said, helps you to get the orientation and how to relate to one side or the other of the monitor. Always check the position of the probe before you start your scan. Now, what are the major things to note about doing a transabdominal scan? You get a good overview, panoramic view that shows you a wide area, but because of the low frequency that is applied, this often results in poor resolution. So you're going to be seeing more of what is close and far less of what is shown below. And then large masses will be seen because you get a wide cover, and you often will need a full bladder. That's usually important so that you can use it as a window, an acoustic window, to be able to visualize the pelvic structures. You can do this in both sagittal and transverse planes. Compare that to, this is the same thing. So this is a sagittal plane dividing the body into right and left. This is what you see. And then for the transvaginal probe, the frequencies are usually higher, and so you get better resolution, but you see only small areas. So you can't see very large masses. If you have a large uterus and you start with a transvaginal probe, you will need to assist that examination with a transabdominal probe. So for the transvaginal probe, you get better image resolution, but image quality will be impaired or you have gas-filled bowel, or you have a woman who is obese. Panoramic view of the pelvis is poor. You won't be able to see beyond there. The advantage, again, is you can do it anytime. You do not have to have any special preparation. In particular, we actually insist that the patient empty their bladder for some type of examination because you want to have a clearer view of what you need to see, because a full bladder might obscure your image with a transvaginal probe sometimes. You don't need to ask the patient to be waiting, because if you want to do a transabdominal examination and the patient needs to feed the bladder, that means they'll be waiting. And so you're able to do it on time. However, disadvantages do also limit its utility. We have said that you can't see the upper abdomen. You need to assist with the transabdominal probe. And some women may not be good candidates for a vaginal examination because they have intact hymen. And sometimes you need to adjust the orientation to be able to get exactly what you need. Sometimes you may need to do it transrectally if the transabdominal vaginal route is not acceptable. And many people may not also like this. So in terms of improving the output of your scan examination, sometimes talk about dynamic scanning, where you involve some manipulation of the pelvic structures to be able to determine exactly what you're looking for. You can see this done sometimes when it's difficult to examine for the ovaries, and you need to either do a bimanual examination with your hand on the abdomen and the probe in at your other finger. You're trying to determine what exactly you are examining for. In other situations, it may also help you in determining whether there is fixity in terms of patients who may have endometriosis or pelvic adhesions as a result of previous surgeries. And so if you have a sliding sign, it means there is mobility. Whereas if you don't have a sliding sign, it means there's some level of fixity. So it helps you in giving some clarity to your findings. Now, the orientation of scanning procedure, we have said what the marker does to help you in the sagittal and transverse views. And then in the transvaginal scan, we've also mentioned how the marker helps you to get orientation. Note that in transvaginal scanning, where the footprint is at the top, the marker will usually be on the left of the screen. But in some other climes where the footprint is from the bottom, then this will be the reverse. So it's also good to remember that this might be the case. So I'll show us some images to display this in a short while. Always instructive to use the finger to determine the orientation during scanning. That's what I mentioned earlier on. Okay, now, again, some comparisons. Again, this is just to illustrate and emphasize a few things, that a trans-abdominal probe can be a good adjunct to a transvaginal scanning. That means you will need to do a trans-abdominal examination if you are not getting details from the transvaginal approach. But this time, you're not going to ask the patient to go and wait anymore to fill the bladder. So you will have to do it without filling the bladder, because what you're examining for at this stage is actually in the abdomen, not necessarily in the pelvis. So getting to see it will not require filling the bladder. So when you do trans-abdominal scan as an adjunct, you usually don't have need to fill the bladder when you do it. So it will not require full bladder. Now, if you see what's in this pictograph, this is a sagittal view trying to display the pelvic organ through a transvaginal probe. You can see how the image captures the uterus, the cervix, a bit of the rectum, and a bit of the bladder. And if you need to change the orientation to get more of the posterior view or more of the anterior view, you can simply just move the probe in one direction or the other. So if you take a coronal view, this is what you also find. You're able to see the uterus from right to left. And so this is the view that best gives you the imaging of the ovary. So you can see the ovary on the right as well as the ovary on the left when you scan in this view. If you don't see it, then you may need to adjust, because really you don't actually get the ovaries in a sagittal or coronal view all the time. You may need to manipulate the probe in different directions to be able to get the ovary, like I made allusion to earlier. Now, a few comments about the Anglo-American versus the European imaging that you will find, depending on the machine that you are using. The Anglo-American view is what we're often used to in this part of the world, where you find that the footprint comes from above, and then the uterus is defined with the fundus toward the left of the screen and the cervix toward the right of the screen in the transvaginal probe. But if you actually take a closer look at it and you remember the anatomy, this is like reversing the anatomy upside down. So the other European style of viewing this image is what follows the real anatomy. But we become oriented to this, and so it's very easy for us to appreciate what we are seeing. Otherwise, this view would have been the appropriate view that depicts just the way the anatomy is. So you get a probe from below, the footprint is coming from below. So you see the fundus bending over the bladder. And so the fundus is to the right of the screen and not to the left. And then you see the other images of the ovary as the case may be. So if you put the two of them side by side, this is what you see. So it's just like a reverse of what the Anglo-American image is that you find in the European imaging technique. But it's important that you understand both of them. So when you have a view that comes with the footprint from below, you're able to interpret it so it doesn't get confusing, because you're already used to this Anglo-American style where the footprint is from above. Again, that's the same thing, showing what the difference is between the Anglo-American and the European. Otherwise, you may misinterpret the uterus as retroverted if you are not sure exactly what it is that you're seeing. However, it is also possible on some machines to flip the image in any direction, not necessarily because where the footprint is coming from depicts either the Anglo-American or the European approach, but flipping the image sometimes is possible. So you've got to also be careful about that and make sure that the orientation is appropriate. Just like changing the probe direction can also cause misinterpretation of your image. So in terms of application of ultrasound in gynecology, it will mainly be for these indications. So examine the uterus for fibroid or adenomyosis or endometriosis in some instances. Examine the endometrium for the purpose of following through with the menstrual cycle and the changes that take place during the menstrual cycle, or in postmenopausal women to determine the possibility of pathologies in the endometrium, the ovaries for pathologies or for the purpose of investigating infertility or monitoring for infertility management or other anomalies of the pelvic organs. Pain morbidity can be examined or evaluated with scan. Masses other than those you find in the uterus. Vaginal bleeding. IUD placement and monitoring. Follicular tracking. Investigation complications, as well as Doppler or tubal factor infertility and 3D ultrasound. These would be different ways to make use of scan in gynecological practice. Now, this is a view of the sagittal view of the uterus. So you can see the very thin white line in the middle of the uterus, which is the Can you see the slides now?
Yes, sir.
Okay. I guess I'm back on.
Yes, you are.
I was just talking about this thin line, okay, which is the basal layer, the endometrium, before it starts to grow as the menstrual cycle progresses. And then you see it in this view now, where it is a bit thicker than what we saw earlier on. Then you take this is the coronal view of the uterus. This is how you measure it from side to side. So we were talking about measurement of the uterus, that it should have 3 values: the length, then followed by the anterior posterior diameter, and then the transverse diameter. Most times, if you read a scan report, you will find that the middle measurement is often the smallest. That's because that represents the anterior posterior diameter for a normal size uterus. If this transverse diameter is often slightly wider than the AP. So if you find it reported in a different way, it's either because the uterus is abnormal or the person has not used the right pattern to report the uterus. This is what you find in the image of the ovary. So there are areas, cystic areas that depict the follicles, and then of course the stroma in the middle. If you find something like this, we often call this polycystic ovary, but there are clear guidelines for defining polycystic ovaries. The fallopian tubes are usually not visible on ultrasound, except they are diseased. And so you don't see them often. If you find that there's a structure in the adnexal area that is not clearly the ovary, then you should suspect that perhaps it's the fallopian tube. And what you may find around there may be a hydrosalpinx or sometimes swelling with pus that may be due to pelvic inflammatory disease. And so you will have to look out for them. There are some images which suggest that that may be the case. A hydrosalpinx will often look like this, a tubular structure with intervening points of demarcation that are incomplete septa. So you don't see a complete demarcation of areas. So it looks like a tube, but has incomplete septation within it. That's often what you find. You hardly find images like this that represent the ovary. And if it's on the adnexal area, then very likely you're dealing with a hydrosalpinx. The uterus can be defined in 2 ways in terms of its orientation, one to the other pelvic structures and then the other one to itself. So you use the term uterine flexion and uterine version. So the uterus can be anteverted and antiflexed. So if the version is the bending of the uterus forwards, and the flexion is the uterus bending on itself. So if it is anteverted, it's bending on itself anteriorly. Whereas if it's retroverted, it is facing backward. If it's retroflexed, it's bending on itself posteriorly. So you can have the uterus that is anteverted, antiflexed, but may also be retroverted, retroflexed. And sometimes there may be a combination of flexion and version, as the case may be. Mostly what you find is that Following surgery, uterus usually becomes retroverted because of the role played by adhesions, which tend to make the uterus held by some adhesive bands. So this is a retro. This is an antiverted and antiflexed uterus. And this is a retroflexed uterus, also retroverted. So in terms of measurement, this is what I was saying earlier on. The measurement of the uterus sometimes cannot be taken in one sweep. You may have to divide it into segments, occasionally up to 3, to get a complete measurement. Occasionally, the uterus gives itself open for a straight measurement. You can take that, but it must be from the fundus to the cervix. That's for the length. And then when you measure the transverse, the anterior-posterior diameter is taken from the anterior wall to the posterior wall. And then the transverse diameter with the probe changed to the transverse coronal view is from side to side. So the image will be measured as length, then APD, and transverse diameter in that order. So this is what you're seeing here now. This is the measurement of the length depicted in 2 segments, and then the measurement of the AP diameter, and when the probe is changed, the measurement of the transverse diameter. So we have here 3.4, 4.9, and 2.6. So the image that is the longest is likely to be the length. The one that is smallest is likely to be the APD, and then the mid mark will be the transverse diameter. Sometimes you find fluid within the cavity of the uterus. Can be for various reasons. Can be because it's around the time of menses, just at the beginning or toward the end of menses, you may find fluid. You may find fluid, especially in postmenopausal women, and that may be a sinister sign of some condition that is possibly malignancy. You may also find fluid tracking back into the cavity from a hydrosalpinx. So whenever you find fluid and you need to measure the endometrial thickness, it's recommended that you exclude the portion of the fluid. So you take the measurement of the endometrium in 2 segments, anterior and posterior, and you add them. That becomes the endometrial thickness, excluding the portion of the fluid. The next couple of slides will just depict to us videos to put some of these things into practice. I hope you can. We have tried to look at how we can correlate anatomy of the female reproductive organs with findings on ultrasound, and how best to orientate ourselves to the image that we acquire on ultrasound for gynecological examinations, and hoping that this will help us optimize our images for the purpose of improving our practice. Thank you. So perhaps we can have a few minutes before the end of the time allotted to me.
Yes, sir.
So,
the floor is open for questions and clarifications. So please, if you have any question, you can unmute and ask Prof, or you can drop it in the chat box. Thank you, sir, for the lecture. Do we have questions and clarifications? Please, you can unmute or drop in the chat box. Okay, so there is a question here. Where do we aim for placing the probe during transvaginal scan? Is it anterior or posterior fornix?
Well, just like the anatomy we mentioned earlier on, you place the probe in the anterior fornix for the uterus that is antiverted. Whereas if the uterus is retroverted, you won't be able to place it in the anterior fornix because the cervix will be there. So you are going to end up putting it in the posterior fornix. So if you place your probe anteriorly, it tells you where the cervix is, and from there you're able to get your orientation of how the uterus is. And subsequent examination will then determine so. So that's why your probe hits the anterior wall before the posterior wall. If the uterus is retroverted, the reverse will be the case. Your probe is going to hit the posterior wall before it gets to the anterior wall.
Thank you. Go ahead with your question.
Yeah. Sometimes the presentation is made as if you put your probe, you move it to the right, you just point to the right to the side. Sometimes I realize that when you are looking for particularly the left ovaries, is much more difficult. I've always just wondered why.
Okay. Thank you, sir. Because when you place your probe, the way you place the probe, we are taught that the marker should face the right side of the patient,
Yes.
which is on the left side of your screen. So you are going to easily see the right ovary like that. Depending on how the probe is placed, you may have a view of the left as you're going in a panoramic view. So you probably see both ovaries at the same time, depending on the size of the ovary, the uterus, and everything. But because when you are looking for the ovary, you do not necessarily go sagittal corona, you are searching for it. So if you place your probe sagittally, that's how you should begin. You move it to the right, you see the right ovary. If it's not very clear, then you should turn to your coronal view. You will see it. You do the same thing for the left. Yeah, transvaginal. That's what I'm telling you now. For transvaginal, your probe should go to the side in a sagittal orientation.
Yeah.
When you get there, if you don't see the ovary, then you turn to the corona. It's best to do it this way because it gives you some orientation. The same thing should be done for the left side also. You should also go to the left adnexal area sagittally and then turn to the corona direction for you to be able to fan up and down to look for the ovary. Because most times you have to search for the ovary. It is when you still don't see it that you should aim for the vascular sign of the internal iliac. Then that will help you.
Thank you.
Yes.
All right, thank you for the response. So you have another question here. Please, can you kindly shed more light on measurement of the endometrial thickness?
Okay. It depends on if you are measuring the endometrial thickness for the purpose of following up a woman who you are managing for infertility. Usually you do it in the mid-cycle period. So you are looking out for the endometrium that is trilaminar, has a midline, and then the thickness is measured from the anterior wall to the posterior wall. So you're going to measure from the anterior wall across the midline to the posterior, and you do it at the widest part toward the fundus. There are times you find that the endometrium is looking like a leaf with the widest part, almost like the mid segment of the uterus. You will have to take that mid segment of the uterus as your endometrial thickness. But where it looks like it tapers toward the cervix and it is widest toward the fundus, then you take the widest part of the fundus as your endometrial thickness.
Thank you very much.
I would like to know. I recently did a transvaginal ultrasound for a postmenopausal patient, and I was measuring the endometrial thickness. Okay, I saw all that hyperechoic area delineating the endometrial thickness, but of course the triangular line were not there because she's postmenopausal. Yet she's not seeing her period, and the endometrial thickness was up to 8 to 9 millimeters. So I was wondering, I mean, I expected that because she's postmenopausal, it would just be 18 line, less than 5 millimeters. But this one, it was up to 8, 9 millimeters. And I was wondering what could have caused that.
Okay, for a postmenopausal woman, there are some recommendations on what to do with the thickness in postmenopausal woman. Before now, the cutoff used to be 5 millimeters, sir, like you said. So whenever you get 5 millimeters or more than 5 millimeters, you get suspicious. But it really doesn't mean that there's a problem. It just means that there's a slightly increased risk, about 7% increased risk for malignancy in such patients,
but
so they should be followed up. Okay.
This patient, I gave a progesterone to see if I could cause maybe some, because
some shedding.
Why is it? Yes, but there was no
response.
No result, no response.
Yes.
Yeah.
So the question is, nowadays, because of women, especially abroad, who may be.
I'll tell you what I did. I did an ERPC kind of, or rather evacuation of
endometrial sampling.
Endometrial, yes, sent for histology, and started my estrogen, and I got a trilaminar line.
Okay. Yes, because that woman, even if she's postmenopausal, if you were to do IVF for her, you will treat the endometrium with estrogen, and it will be trilaminar. The trilaminar is just a suggestion that the endometrium has become estrogenized.
Yes.
From the basal layer, which should be thin. Yes. And that's why we say women who are on tamoxifen, for example, should not be subjected to the same cutoff of 5 millimeters. For them, it should be a minimum of 8 millimeters because of the exposure to such drugs before you get worried for them. Yes.
All right. Thank you.
Yes, sir.
All right. Thank you very much, Prof. Thank you for all the participants that have asked questions. I will just take the one more question, and that's it for today. Okay, so that we can all go and rest. Please, when is the best time in the menstrual cycle to do a gynae scan? That will be the last question for today. When is the best time in the menstrual cycle to do gynae scan? Prof.
Okay, that looks like a very vague question. Gynae scan for what indication will be the first thing? Are you looking for follicles? You will do it multiple times. Are you monitoring the endometrial changes across the menstrual cycle? You probably also do it multiple times. Or are you looking for evidence that the woman has ovulated? You will do it later on in the mid-luteal period. So it totally depends on what you're asking for. So the indication will determine when you best do a scan. If, for example, you want to do a scan to assess the potential for a woman to have good follicles when you stimulate them, you will do it very early in the 3rd or 4th menstrual day to look for antral follicles. So the indication determines when you do it. If you want to look at the endometrium to see how it is responding and you're planning out for another cycle, you want to take samples from it, you do it in the mid-luteal period. Except maybe the person wants to modify the question a bit to know exactly what they need to know.
I think the response is clear. Thank you very much, Prof. On behalf of everyone, I appreciate you for the lecture. Thank you so much for the apt responses also. And for all the participants, thank you so very much. Thank you, Professor Enaruna. We are very grateful and privileged to have you join us this evening.